Hello, gentlemen and ladies. Today's topic is schizophrenia. We have a number of slides coming up that I'm going to need to cover some basic background material on schizophrenia. And then at the very end, I have some videos, case studies of two gentlemen, one lady who are actively schizophrenic, so that I become not just a talking head, but a person who actually shares a bit of schizophrenia with you. The first thing I'd like to do is share with you this word psychosis. And notice please it's not the word psychopath. We covered that in an earlier video. But the term psychosis refers to the loss of contact with reality. Schizophrenia is not the only psychosis out there, but it's by far the most frequently occurring one. And to make a diagnosis of schizophrenia, one or the other of these two things need be present, though oftentimes both are present. First, hallucinations. Second, delusions. Let's pay attention to them for a moment because sometimes people get the two mixed up. When you think of hallucinations, think of the 5 traditional senses: sight and hearing, taste, touch, and smell. A hallucination is a false sense perception. Now, in the movies, schizophrenics see things. In reality, though, schizophrenic people typically hear things. That's to say, they hear voices. Now, new students sometimes might say to themselves, well, okay, the schizophrenic person thinks they're hearing voices. No, they are hearing the voices. Of course, the voice or voices are not actually there. Now, we do have 3 other senses. We've also have a sense of touch, and perhaps, I do remember one patient I saw for a while, he thought that his insides were being eaten. He could feel the pain. I knew a person who thought he had body odor so bad that nobody could be in the room with him, as a result of which he was taking 14 showers a day, and needless to say, he didn't have any smell to him at all. And some people believe that they can actually taste the poison in the food that's being fed to them, and so then they perhaps only eat food that comes directly from a can that they open themselves. So 5 traditional senses. A false sense perception, that's a hallucination. A delusion does not include one of the senses. It is an absurd false belief that a person firmly holds to in spite of evidence to the contrary. If I said to you, I'm a good teacher, well, you might agree with that, you might not. If I said to you, I'm the greatest teacher who ever lived, you might think, well, that's pretty conceited. If I told you, well, the greatest teacher is Jesus Christ, and I'm Jesus Christ, okay, now we get into the business of psychosis, an absurd false belief, yet I hold to it, shall we pretend. So that's the difference then between hallucination and delusion. Now, in relationship to schizophrenia, we have a couple of different types of symptoms. Let's take a look at those now. And what we want to talk about now are positive symptoms and negative symptoms. Please, positive does not mean desirable. Negative does not mean undesirable. When you think about the word positive here, think about a plus sign as in arithmetic. Something has been added to the person. And if we take a look at the laundry list up here afterward, we see that our schizophrenic person is hearing some extra things that the rest of us don't hear, voices. They have some extra and unusual beliefs. They have some extra and inappropriate affect, which is to say display of emotions, such as laughing at the news that the airplanes have hit the Twin Towers. So, positive does not mean desirable, it means they've got some extra stuff added. Negative does not mean undesirable. Negative means removed, subtracted. What's been subtracted from them? They've lost all interest in other people around them. They become completely withdrawn. They may lose interest in any behavior that allows them to adapt to society. They have removed from them all emotions. So on news that their mother died, they say, whatever, or maybe less than that, and they lose the inability to think well. Now, every patient does not display positive symptoms, but many will have a tendency to display more of them, and some other patients will tend to display negative symptoms. Now, on the whole, if you've got to be a schizophrenic, you're better off having the positive symptoms. The reason for this, we also talk about a bit later, medication tends to be better at removing positive symptoms than it does in helping people get back in touch with acting appropriately. In other words, it does not work so well with negative symptoms. Now, in both cases, you tend to have some cognitive symptoms, which in this case means thinking. Cognitive always means mental events, and many schizophrenics will have some problems with thinking. Now let's take a look at a few statistics regarding schizophrenia. Schizophrenia is a fairly frequently occurring disorder. About 1% of the population is schizophrenic. So in a country like the US of A with 300 or so million people, take 1%, you come up with 3 million schizophrenics, 3 million people who are out of touch with reality, at least some of the time. Schizophrenia tends to have its onset early in life, somewhere between about 15 or 16 and age 30. It rarely occurs after age 30. And after it does develop, it tends to be a lifelong disorder, which is to say, chronic. Now, wondering about what the cause of schizophrenia is? It's related to both heredity and the environment. It's about 50% caused by heredity. We know this because if one identical twin develops schizophrenia, the other one also does 50% of the time. So, hello, that's quite a large percentage. And if you take a look at the information on the screen, you can see as however close a second person is related to some other individual who does have schizophrenia, the less closely related they are, the less likely that person is to be schizophrenic. The more closely related, the more likely. And so, indeed, schizophrenia does run in families. Now, after some number of years, one can expect that there will be changes in the brain itself. The brain becomes smaller, the open areas in the brain that are typically filled with fluid become larger, and that means then that there's less brain matter present. There tends to be an excess of dopamine in the brain of schizophrenics as well. Schizophrenia is also related to poverty, malnutrition, and other diseases, but those things alone will not bring about schizophrenia. Now, it's possible that there may have been some prenatal stressors that contributed to the likelihood of developing schizophrenia. Psychiatrists in Australia are investigating this right now, but the data is not yet in. Now, every person who's schizophrenic is not necessarily actively psychotic at a particular moment. If they're on medication, they may be doing quite well for a while, but then if you throw in some life stressors such as loss of a job, problem with a relationship, then they may become actively psychotic again for a while. Now, there's many reasons to avoid messing around with drugs. One thing that does happen occasionally, though, is that some individuals who perhaps are unlucky enough to have the genetic makeup that would contribute to the likelihood that they will become schizophrenic, then they try some drug, whether legal or illegal. They have a psychotic break and they don't recover from the psychotic break, and after 6 months or so, the diagnosis is changed to schizophrenia. Thank goodness there are treatments for schizophrenia now. Before about 1950, there were no treatments, but there is medication now for this lifelong disorder. The good news is, About 1/3 of the time, a schizophrenic person will live a fairly normal life as long as they take their medication. If they stop taking their medication, wait a few weeks or months and they will slip back into active psychosis again. But stay on medication and have a typical life. About 1/3 of the time, the person will have a partial recovery to schizophrenia, and they will live actually a fairly minimal life. So you might have a person as a college student planning on becoming a CPA and making good grades in accounting, becomes actively schizophrenic, and medications don't work so well, and they take a job on their uncle's cleaners, working in the back pressing shirts, and they go home and they watch television, and they do that for the next 60 years. That's a pretty minimal life compared to where that they were going before. But it's far better than the outcome for the remaining third, where the medications typically don't have an effect, and then they spend the rest of their life in the back bedroom, or perhaps in a mental hospital, or perhaps they become homeless and live under a bridge. Perhaps they live in a halfway house and then die an early death. Sadly, schizophrenia is so misery-making for many people that a fairly significant number of schizophrenics actually commit suicide. What I'd like to talk with you now about is some case studies in schizophrenia. The first one won an Academy Award as Best Movie of the year 2002. It's the story of John Nash, an economist who later in life won a Nobel Prize for his work in economics, but he had a schizophrenic break early in his life that left him out of touch with reality for about 30 years. Most unusually, he recovered from his schizophrenia and was given the award later in life. This is a very well done movie. Dr. Nash saw the movie himself later and was asked whether it accurately portrayed him, and he said yes, it was right on, with one exception, and that is it being a movie, they had him see things as part of his confusion, but he said in fact he actually did hear things. He heard voices telling him things. So I'm glad to recommend that movie to you. Seen it a number of times myself. It's absolutely first class. What I'm going to do now is provide brief introductions to 3 case study videos, each about 5, maybe 8 or 9 minutes long, that I always show in class. I do invite you to take a look at these, and I'll be introducing them one at a time. The first case study is about a young man named Augustine. The reason I like this particular case study so much is that the first part of the film, you see him when he's off medication, rather confused. Then he's on a new medication for a month or two, and then, well, take a look at yourself. He's much better. So to watch that case study, look for the link that'll show up in the upper right-hand corner. To watch the case study about Augustine, hit your stop button now, back up, click on the link. The second case study is of a young lady named Heather. She's on a home visit. You meet her mother, who describes her gradual deterioration into an active psychosis. It's very interesting. Click on the link named Heather to watch this video. Hit stop now if you missed that link. Go back, watch the video. The next video comes in 2 parts. It's a bit longer. In some ways, it's the best of all. In fact, as it begins in the first part, you are yourself then at a mental hospital, as if it's the first day on the job for you as a psychiatrist in training. You look around, there's your fellow colleagues, and a senior psychiatrist, a psychiatry professor, comes in and says, here's a first patient to look at. So look now for the link to Gerald Part 1 and watch it. If you missed that link to the Gerald video Part 1, hit stop now, back up, watch it. I invite you now to watch the second part of Gerald. He makes a home visit, spends some time with Dad, and you get some idea of what it would be like to live with him, an actively schizophrenic person, at home. Yes, if you missed the link to Gerald Part 2, hit the stop button, go back, catch that video. Here's hoping you found this video interesting, valuable, and educational. You take good care of yourself now and have a great psychology day.
Thank you very much. Of course,